Hi, everybody. Welcome to our APTA live event. My name is Jodi Pfeiffer, and I'm a physical therapist assistant up here in Alaska, currently serving as one of your PTA Caucus Delegates. Tonight, we'll be talking about issues facing the physical therapy profession with our focus on proposed Medicare payment cuts and why speaking up and speaking out is so important. I'm here today with Justin Elliot, Vice President of APTA Government Affairs, and Kara Gaynor, Director of APTA Regulatory Affairs. Thank you both for being willing to be here with us today. Justin and Kara, can you tell us a little bit about what you do with APTA?
Sure. Thanks, Jodi. Thanks for having us on tonight. It's great to be here with you. My name is Justin Elliot. I'm the Vice President of Government Affairs at APTA. So in my role at APTA, really focus on the work that we do aimed at Capitol Hill with the U.S. Senate and the U.S. House, and of course how we engage our members through grassroots and through our Political Action Committee to advance APTA's policy agenda.
And I'm Kara Gaynor, APTA's Director of Regulatory Affairs, and I lead a team of regulatory affairs professionals to represent and promote the physical therapy profession before federal agencies like the Centers for Medicare and Medicaid Services, CDC, the VA, Department of Defense, and many others, as well as other national policy stakeholders on a wide range of topics, including coverage, payment, coding, billing, and other policy issues that impact the entire continuum of care.
Great, thank you. So we've heard a lot about CMS and Medicare cuts regarding E&M codes. Can you tell us what these are and how they affect us?
Sure, yeah, I'll start and then I'll turn it over to Justin. And before I really go into the details, I do want to just start off by saying that the physician fee schedule under which these cuts have been proposed was developed in 1992, and it's an inherently outdated payment system. And it really doesn't reflect the modern healthcare delivery system in which healthcare professionals like PTAs are working collaboratively with other healthcare professionals. And so when policy proposals like this cut are put forward, and it simply is building off of a flawed payment system, APTA and the entire physical therapy profession, as well as our patients, need to use our collective voice to educate and inform CMS or whoever the decision maker may be about the impact of these policies, which in turn can influence change. So in terms of the 9% cut, I know there's been a lot of confusion about where this cut actually came from, why CMS is proposing it. So first, I'll just start off that discussion by saying there are annual updates to the RVUs of the CPT codes that are included in the physician fee schedule. And these updates are based off of recommendations that come from the AMA's RVS Update Committee, or the AMA RUC. And those recommendations are based off of survey data that the AMA and other national specialty societies, including APTA, collect. And those recommendations are transmitted by the AMA to CMS. CMS evaluates those recommendations and decides whether they want to adopt those recommendations, increase the values, decrease the values. They are the final decision maker. And so when the fee schedule is proposed and published in the Federal Register every summer, they are publishing the proposed values for that upcoming calendar year for the various CPT codes. So if you recall, it was actually last year, CMS had released the 2020 fee schedule proposed rule at the end of July. And CMS had proposed the values that they were planning to assign to the office outpatient evaluation and management visit code set. And the recommendation and the proposed values for actually 2021, they were delaying it a year, were based off of the recommendations that they had received from the AMA. In addition, CMS proposed, it was not something that the AMA had put forward, but CMS on their own proposed to adopt an additional code, an add-on code that was designed to address the additional resources that they feel are inherent in visits for primary care. And so what this resulted in that we saw in last year's rule, and obviously again reiterated in this year's rule, was a proposal to significantly increase reimbursement for this code set that are billed primarily by primary care physicians and some other specialty physicians, in addition to this add-on code that would be billed by providers who bill E&M codes. But because of a policy called budget neutrality, which I'll talk about in a second, you saw corresponding decreases of varying amounts for about three dozen different healthcare providers, including physical therapy, occupational therapy, and speech language pathology. And last year, CMS had estimated that the cuts needed to offset the increases to the E&M codes as well as the add-on code would be about 8%. And at the time, obviously, when we saw that policy included in the rule, we knew that there was obviously going to be a lot of advocacy to stop CMS from finalizing this policy to take effect on January 1, 2021. So in terms of just budget neutrality, because I know this is a long overview, but I just want to make sure that the audience knows there's a lot that goes into this. So the statute requires CMS to maintain budget neutrality in the fee schedule. And so that means that changes to the RVUs can't increase or decrease expenditures for each year by more than $20 million over what they would have been. And so because the increases are so significant to the office outpatient evaluation and management visit code set, in addition to the add-on code, that's why we're seeing such significant decreases because to other providers who don't bill those codes, because CMS has to maintain budget neutrality, meaning they had to cut payment elsewhere to make room essentially for the increases to the E&M codes. And I want to emphasize that we do not oppose the increases to the E&M codes. We understand the rationale behind the increases to those codes. It's been a policy goal of CMS, the Medicare Payment Advisory Commission, and others to revalue these codes for quite some time. But obviously, the increases are so significant, and because of the budget neutrality requirement, it clearly hurts a lot of other healthcare providers. So CMS, in this year's rule, had proposed to, continue the policy that they had said they wanted to implement in 2021 in last year's rule. And so in this year's rule that came out in early August, the fee schedule proposed rule for 2021, CMS proposed to maintain budget neutrality by reducing the conversion factor. And the conversion factor is used to calculate the payment for codes once the codes RVUs and geographic factors are calculated. Essentially, it's the number that is used to formulate payment rates each year for each CPT code. And so in this year's rule, CMS said that to maintain budget neutrality under this policy, they would be reducing the conversion factor by almost 11%. And so that obviously has a significant impact on all providers who bill under the fee schedule. And the overall impact does vary by specialty because it will vary based on the value of the codes, of the RVUs of each code, and whether the RVUs are increasing or actually decreasing, because that is separate from this conversion factor adjustment. And in fact, CMS is proposing to significantly increase the values of PT evals and re-evals. However, because the conversion factor reduction is so significant, you still see that overall estimate of a negative amount. So that's kind of what led to CMS saying in this year's rule, we're reducing the conversion factor by almost 11%. The estimated cuts to three dozen providers are varying amounts. As we know, CMS estimated it would be a 9% cut to PT, OT, and speech, which is obviously even worse than last year. So I want to emphasize, and I'll turn over to Justin in a minute, but since this policy was initially proposed last summer and then again included in this year's fee schedule rule for implementation in 2021, we knew that we had to stop this policy from being implemented. And so we have we launched and we continue to engage in a legislative, regulatory, and communication strategy, and have really been fighting this policy since it was proposed last summer. And just to give you a sense of some of the advocacy, the regulatory advocacy, which is directed to CMS and other federal agencies, since last summer, we not only submitted comments on last year's rule opposing the cut, we also met with CMS along with the other therapy associations to discuss the cuts and our concerns with the expected cuts. We also did a letter writing campaign, and thousands of PTs, PTAs, students, and patients did submit comments on last year's rule opposing the cuts. Then once we saw that CMS indicated in the final rule published on November 1st of last year that they were going to be moving forward with this policy, we then proceeded to meet with HHS leadership, CMS staff who are responsible for this policy. We formed a coalition that submitted correspondence on behalf of the coalition to CMS, outlining the concerns with the cuts and offering recommendations on ways to get around the cuts, mitigate the cuts, get rid of the cuts. We also sent our own correspondence to CMS earlier this year, and we also sent a letter to the Medicare Payment Advisory Commission outlining our concerns with the cuts and why we felt they needed to engage with CMS on this issue, given the impact of the negative cuts on PT and many other providers. And then we also met with the Office of Management and Budget, which is an agency or an office within the White House that has to review every rule before it's published. We met with them earlier this summer. And then actually on this year's rule that was published in August, APTA submitted 2 comment letters, a 23-page letter and then a 55-page letter, both outlining the concerns with the cuts and offering recommendations on ways to mitigate or eliminate the cut. We did a huge letter writing campaign, which I'm so proud of. We had more than 25,000 letters sent from the profession and patients and supporters. And actually, I think that number is closer to 30,000, if not over 30,000. And actually, that's out of a total 45,000 comments sent to CMS. So the PT profession really dominated the comment letter writing process to submit letters to CMS opposing the cuts. And then we did actually meet with CMS leadership during the open comment period. And then we also, which is something that I don't know that any other association actually did, because of the implications that the Medicare cut has on other government programs like the Tricare and the VA community care program, and then obviously implications with commercial insurance. We actually reached out to the VA and the Department of Defense, which administers Tricare, to basically let them know that this was coming and that this was going to impact access to their enrollees and their veterans should this be implemented. And so we do know that the VA ended up talking about this, and we theoretically, I think, well, I'm not sure. We hoped that they would basically reach out to CMS and HHS and say, hey, we're concerned about how this will impact access. Because obviously hearing from other federal agencies about concerns with the cuts really does go a long way and would really support our messaging to the agency. So that kind of gives you a sense of where this policy came from, what kind of the regulatory advocacy has been done over the last year. But now I'll turn it over to Justin because there's been a lot of activity on the Hill over the last year.
All right. Well, thanks, Kara. And, as Kara outlined, it's just been a tremendous advocacy effort by PTAs, APTA members, patients, our colleagues and friends to really make some noise on this policy, both with the federal agency, CMS, but also with Capitol Hill. We know that this policy is scheduled to go into effect on January 1st. The clock is ticking. And so while we've done a very robust advocacy campaign aimed at CMS and at Medicare, we've also have been engaging with Capitol Hill, with members of the U.S. Senate and the U.S. House, because we want Congress to intervene. We want them to step in and fix this proposal and basically stop the cuts from happening. Because as folks watching know, this is going to have a huge impact on the PTA team. It's going to have a huge impact on therapy clinics, particularly in rural and underserved areas. And that's going to impact patient access and the ability of patients to get the care that they need. And so while we've also been working not just by ourselves, but again, as Kara mentioned, we are part of a coalition. 37 other provider groups are slated for deep cuts: radiologists, pathologists, orthopedic surgeons, you name it. And so we're working both alone, but also in partnership with other providers to, again, raise this issue on Capitol Hill. And thanks again to the advocacy that many of you watching have done, Congress has taken notice. And so over the past year, along with the APTA staff and our federal affairs liaisons, those members who are engaged in advocacy, we've done something like over 300 meetings with members of the Congress just since March 1st on this issue. We've had over 100,000 emails and letters generated by members, by patients, aimed at Capitol Hill, again, urging Congress to intervene and to stop these cuts from happening. We've had members of the U.S. House come together in bipartisan fashion to write letters both to CMS. We had a letter about 3 weeks ago that was signed by 161 members of the U.S. House, Republicans and Democrats, coming together to write to the Secretary of HHS and to CMS, basically saying, you really need to rethink this proposal because the cuts are going to be devastating. And then earlier, just this week, we had 229, again, bipartisan members of the U.S. House sent a letter to Speaker Pelosi and Leader McCarthy, basically saying it's time for the U.S. House to intervene. We've got to do something legislatively to stop these cuts from happening. So we anticipate that Congress will take legislative action. We're optimistic that they will take action before the end of this year, and that will either delay or prevent these cuts from happening. And that's where you come into play, because it's really the PTAs and patients and members and students who are raising their voice, whether it's through emails or phone calls, participating in Zoom meetings with their legislators, social media, that has been critical in making sure that members of Congress are aware of this issue and know that they have to act, because we need them to act. Because again, this is something that's going to impact PTAs and PTs, the PT-PTA team. It's going to impact our patients, but it's also going to have a dramatic effect on the entire U.S. healthcare system, given that 37 other providers are also impacted. So thanks to everyone who's been participating in our calls to actions. We have just a few short weeks to get something passed through the Congress. So stay tuned for more action alerts, and appreciate all of the support that you all have been providing during this advocacy effort.
Okay, I want to remind everybody watching, if you have any questions, please type them in the chat and we'll try and get those answered. So what I'm hearing, guys, is this is something that affects all of us, just our profession as a whole, PTs and PTAs. It's not directed in one area or the other, and we really need to work together on this. We will watch for those action alerts to come out and definitely participate with those. Is there anything else we should be doing in the meantime?
Well, I think, first is just to stay tuned to all the information and resources that we have available. If you go to apta.org/fight the cut, we have a lot of background information and resources, not only for PTs and PTAs to utilize, but for patients. And it's important to just keep up to date as to what's going on, because we anticipate that there's going to be a flurry of activity during what we call the lame duck session. Congress right now is out. They're going to come back after the election, and that's when things are going to be picking up real quick. So it's important to stay informed, see the resources, but also tell your colleagues, tell your patients, tell your neighbors, tell your friends. This is something that impacts everybody. And the folks who are going to be the one raising the alarm are the folks watching this, the PTAs who are going to see this firsthand. And so I think the biggest thing is just spread the word and let folks know about what is going on with this Medicare proposal.
Okay, great. Another hot topic that we're having a lot of questions about is telehealth. Can you tell us what has changed regarding telehealth?
Carrie, you want to take a first stab and I'll tell them what's on the horizon?
Yeah, sure. So as we know, during the public health emergency, during the time when the Secretary of HHS, Secretary Azar, has declared a public health emergency and there has been a national emergency declared by the president, CMS has a ton of flexibility to issue waivers and give and waive various regulations and policies to allow providers to furnish care and not be burdened by the public health emergency and the usual regulations governing them. And so telehealth is one area where, due to advocacy, actually, Congress did give CMS the statutory authority to waive some of the all of the regulatory requirements related to telehealth back in March. And then CMS didn't have to, but they chose to use that authority granted to them by Congress by recognizing physical therapists in private practice, physical therapist assistants in private practice, and then facility-based therapy providers as eligible to furnish and bill telehealth under Medicare. And I do want to point out that that doesn't necessarily mean that CMS would have used that authority. Granted, they did realize that their Medicare patients needed healthcare and telehealth was really the only option. So it likely would have happened, but I do want to emphasize that there were thousands of emails sent to CMS during the time frame after which Congress had given them the authority, urging CMS to take advantage of that authority. And I actually had spoken with one of the CMS regional office leaders during that time period. And basically he said, we know you guys want this. We're working on it, give us some time. So I just want to emphasize, I share that because I just want to emphasize that your voices matter, they count, they get attention. So I did just want to share that. So where we're at right now is those providers that I just mentioned can furnish and bill telehealth under Medicare. Also under Medicare during the public health emergency, there is permitted, obviously we know PTAs in private practice are subject to the direct supervision requirement under Medicare, even if state law has a different requirement that is more flexible. CMS has said during the public health emergency that direct supervision can be accomplished and can through technical means, through audio and visual technology, when that's necessary to reduce exposure risk for the beneficiary or provider. And so it doesn't even mean that the PT has to be on the phone or video, but they have to be readily available via phone or video, just as they would be readily available in the office suite when directly supervising the PTA. So that is a flexibility that's been afforded to PTAs as well as PTs in the private practice setting. And on that point, I will note that APTA has been advocating for quite some time that CMS allow general supervision of PTAs, given that that is more aligned with state law. And we're hopeful that CMS will see that it makes sense to align with state law, as that's something they're doing in more and more policies that they roll out. They are trying to align their requirements more with state law, where it would make more sense to align with state law. So it's very possible that CMS will make that policy change in the near future, which we're very hopeful for. But so that's kind of where we're at. We're in a holding pattern. As long as that public health emergency, those two declarations are in existence, telehealth under Medicare is allowed. But we obviously want a permanent fix, and that's where Justin comes in.
Yeah, so what's interesting about what's happened over the last several months with the declared public health emergency, there are two issues that we've been fighting for. One is the use of telehealth by PTAs and PTs under Medicare. And the issue, as Kara mentioned, was also providing more flexibility on the supervision requirements for private practice under Medicare. And so, we're looking at ways that, even though these flexibilities are allowed during the public emergency, how can we make some of these permanent? Because these are issues that are critical to PTAs. These are issues that are critical to patients. Now, on the telehealth issue, I will tell you that we anticipate legislation being introduced hopefully next week that will basically make permanent the current flexibilities allowed for physical therapy, occupational therapy, speech, and audiology. And this will be a bill that will, if enacted, basically would amend the Medicare statute to say, yes, for Medicare, you can do PT, OT, speech, and audiology and get reimbursed for it. And that would include, for PTs and PTAs. Now, the question is, we need to get that enacted by Congress before the public health emergency is declared over. We don't anticipate that the public health emergency is going to be declared over anytime soon, or at least it shouldn't be, because I think everyone in public health agrees that this is something that it needs to stay in place for the foreseeable future, given the ability of the current COVID pandemic. So we anticipate that the current flexibilities will be allowed as a result of the public health emergency. But that gives us, good news is that gives us more time for us to lobby Congress to get them to pass this bill that we anticipate will be introduced next week. There'll be an action alert asking folks to contact their member of Congress to get that passed. And so that will be critical to making sure we keep the flexibilities that we've been allowed to do under the emergency. So stay tuned for that. That's going to be a big step forward for us.
Great, thank you. Well, that's very exciting. We will definitely watch for that action alert and be prepared to move forward on it when we get it. We do have a question from Nicole in Texas. She would like to know where we can find the list of the providers that will be affected by the cuts.
It actually is in the 2021 fee schedule proposed rule. And I think we can provide the link and the page number in the comments section. And so if you can find the link, it's in table 90. And so it lists all of the providers and it lists total impact for each specialty. And so it spans 2 pages. It's about a chart of about 1.5 pages, and it's labeled calendar year 2021 physician fee schedule estimated impact on total allowed charges by specialty. And CMS does emphasize that it is an estimate. And obviously a lot can change between the proposed and final rule, which, we're obviously hoping that our advocacy has pushed CMS to reconsider what they've proposed in the proposed rule.
Yeah. And if we're not able to get that link into the comment section, you can always, Nicole, email advocacy@apta.org. We have that chart in a little PDF that we can email to you directly.
Great. So anyone else, you have that same question, you want to see that chart, send that email. All right, can you guys give us an update on PDPM and PDGM? Has there been any changes that we need to know about?
So I'll start just in terms of policy changes. Because of the COVID-19 pandemic, CMS really didn't make many changes to either the SNF patient-driven payment model or the home health patient-driven groupings model. And actually, we're still waiting on the home health final rule for 2021. But what they proposed was very minimal changes under the home health payment system. And it's because of the COVID-19 pandemic, and CMS hasn't been able to collect enough data to analyze utilization patterns or outcomes. And so I think that it will be probably, I don't even know if CMS would propose any changes for fiscal year 2022 or calendar year 2022, given how COVID has impacted data collection and data analysis. But I will say that on the topic of those payment models, we are continually engaged in conversations with the CMS staff who developed those payment models to talk about access concerns, access to physical therapy under both of those models, recognizing that PDPM was implemented. There were obviously a lot of concerns, and then the pandemic hit. And then at the same time, PDGM was just implemented. CMS had to publish an article in early February outlining the role of therapy in home health under the payment model, reminding everyone that there is continuing to be a role for therapy, and that has not changed simply because the payment model changed. So we recognize that COVID has obviously dominated what's going on, but recognizing there are those still underlying concerns with both of those payment models, and recognizing that while the physical therapy profession might be educated and aware of these models, others may not be. And so we did, with the other therapy associations, do some education and outreach to a number of the physician groups that oftentimes refer patients to home health or skilled nursing facilities, as well as we disseminated resources to consumers regarding these payment models so that they understand their rights and benefits. And we do have those resources on the Choose PT website. So I guess although CMS has not been proposing any changes, they do continue to speak with us because we are continuing to receive real-time feedback about what's happening in these settings and what we want CMS to know and consider as they consider making changes in the future.
Yeah, and just I think the big thing will be also, ongoing oversight by Congress and by CMS as to how these models in home health and skilled nursing facilities are working. Just to give you an example, last winter, when we were getting some stories and real life case studies that PTAs and PTs were sending in to us saying, this is what I'm seeing, that's important because CMS is watching. And so is Congress. We were able to have a meeting with the Senate Finance Committee so that we could talk to them and say, this is what we're hearing from our members. We have these PTAs who are saying this is what they've seen. This is, this is real, some case examples as to how implementation isn't going the way it's supposed to. So I think, the one message is that this is something that both CMS and Capitol Hill is going to continue to watch. And so if folks have real life examples as to how the rollout and the application of these new payment models is not going as planned, that's important for us to know so that we can share that with the folks who are going to be doing the oversight of it.
Great. We have a question from Leanne in Alaska, and she wanted to know if you could give a brief explanation about what PDPM and PBGM are.
Yeah, sure. The Skilled Nursing Facility Patient-Driven Payment Model, or PDPM, is a payment model that was adopted by CMS that went into effect October 1st, 2019. And really, it's a shift it's a new payment model toward using a more patient-driven approach to payment for care delivered in skilled nursing facilities under Medicare Part A. And similarly, in home health, the patient-driven groupings model is, again, more patient-driven payment model where they're trying to better align payment with clinical characteristics. And so they're similar in many ways, but still differ in many ways. And actually, I will note that it's important to keep in mind that these are temporary models. These are not going to be models that are here for a very long time, because in fact, Congress and CMS and the Medicare Payment Advisory Commission have all been looking at developing a unified payment system that would span the 4 post-acute care settings: long-term care hospitals, inpatient rehab facilities, skilled nursing facilities, and home health agencies. And so actually, the Medicare Payment Advisory Commission, which advises Congress on Medicare policy issues, they have submitted reports to Congress about how a unified system could be developed. The Centers for Medicare and Medicaid Services has actually convened a technical expert panel upon which APTA sits that is looking at how they might develop a unified payment system and a template for such system. And then those recommendations are going to be submitted to Congress for their consideration. But we do know that Congress is interested in passing legislation that would require CMS to develop such a unified payment system. And so we are involved in every one of those discussions. And, we want to make sure that a unified payment system truly captures the value of therapy across these settings, while also recognizing that patients have different needs and needs of different intensity of therapy. And so making sure that those characteristics are in fact accounted for in development of this new payment model.
Okay, great. Thank you for answering that. Okay, we've also had some changes in maintenance therapy. Can you explain a little bit to us about what's changed with that?
Sure, I'll start. So as you all know, or as some of you may know, beginning January 1st of this year, CMS does now allow physical therapist assistants to furnish maintenance therapy in the home health setting when furnished under a home health plan of care. And this was to better align maintenance therapy policy that is in the skilled nursing facility setting, where PTAs are allowed to furnish maintenance therapy in that setting. However, I will note that during the public health emergency, CMS is temporarily allowing PTAs to furnish maintenance therapy across outpatient settings under Medicare as well. And in fact, this is something that APTA has actually been advocating for a couple years now. And because of our advocacy for this change, and because CMS temporarily allowed it, and in fact, we've been now supporting CMS for that temporary change and urging them to make it permanent, CMS has proposed in the 2021 fee schedule proposed rule to permanently allow PTAs to furnish maintenance therapy across all outpatient settings. So there would no longer be this dichotomy of, okay, you can do maintenance therapy in this setting, but not in this setting. It would all be the same policy for SNFs, home health agencies, and outpatient settings under Medicare Part B. So we're hopeful that CMS finalizes that. We did obviously write in support in our comments, urging CMS to finalize that policy. And if they do, it would take effect January 1 of 2021.
All right, great. That would be very exciting for us. All right, we also had a big win in regards to Tricare. Can you explain what has changed with Tricare?
Justin, yeah.
Kara, I'll start
please.
off just to give a little bit of history. Yeah. So, as folks know, this has been one of the longest and probably one of the more frustrating battles we had, because for a number of years, we were working with the Department of Defense on the issue of the ability of PTAs to provide and be able to get paid for the services under Tricare. And after a lot of back and forth with Pentagon, with DOD, on saying, well, of course PTAs their services need to be paid for. They basically, Department of Defense said, well, yes, but it's going to take an act of Congress to do that, because PTAs are not recognized under the federal statute as authorized providers of Tricare. And so folks may remember a couple years back, we had a big advocacy campaign. Again, a lot of folks who are watching were part of that and were critical in getting that bill through the U.S. Congress, which amended federal statute and added physical therapist assistants as authorized providers under the Tricare program, which was a huge win. And again, a great advocacy effort by all of PTAs across the country. I think what was, after the bill got signed into law by the president, it then had to go through the regulatory process, which, as folks know, can sometimes be a long and challenging timeline. But after a lot of work, a lot of advocacy, those federal regulations went into effect. And Kara can kind of talk a little bit about where we are now. But again, this was a great example of PTA advocacy, not only with getting that bill through Congress a couple years back, but all of the comments and advocacy that PTAs did during the regulatory process, which kind of got it over the finish line. So, Kara, I'll let you pick up from there.
Yeah, I'll just add that I do also want to emphasize that the comments submitted on the proposed rule where Tricare was proposing to implement this in regulation, as some of you may recall or know, Tricare made some errors in their references to Medicare regulations and references to various language. And so a key element of our comments were actually, okay, Tricare, you say that you want to mimic Medicare, but you need to make sure that your regulations actually reference the appropriate Medicare regulations. So an element of the comments was not only making sure this was implemented, but also that the regulations were correct. And so it did go into effect like April 16th of this year. And the Tricare manual has been updated, the policy manual, to reflect the addition of PTAs and OTAs. And essentially, Tricare's requirements mimic Medicare, supervision, use of the new CQ and CO modifier, and things of that nature. So if you haven't seen it, check out the Tricare policy manual. I can also provide a link in the comments. And then also the contractors had to update their policies and handbooks to reflect the addition of PTAs and OTAs. So I believe that both have done so. And actually, we haven't heard of any issues with claims processing or any sort of auditing issues. But if you do ever encounter an issue, or a friend encounters an issue where Tricare is denying a claim that was for services furnished by a PTA, please reach out to us and let us know, because obviously their services are now covered. So yeah, huge win, huge effort. It couldn't have happened without advocacy.
Oh, definitely. I mean, that was a huge win for us as a profession, but really the big winners are our patients, right? Who are going to have improved access to care. So that is phenomenal. We have one more question from Marissa, who wants to know if maintenance therapy that can be provided by PTAs is under Medicare A and B, or just one?
So currently the permanent policy currently in place is that PTAs can provide maintenance therapy under Medicare Part A in SNFs and home health agencies. Temporarily during the public health emergency, CMS is allowing PTAs to provide maintenance therapy under Part B. Now, CMS has proposed to make that policy change permanent. So theoretically, if CMS finalizes it on January 1 and beyond, you would be able to furnish maintenance therapy under both A and B in home health agencies and skilled nursing facilities and private practices and other settings.
Great, thank you. Well, we are coming to the end of our time, unfortunately. Do either of you have any final thoughts that you'd like to leave us with?
Well, I'll start off. I think membership matters, advocacy matters, and your voice matters. Policy makers, whether they're on Capitol Hill or CMS or HHS or Department of Defense, they need to know what the role and value of physical therapy means. And every one of you watching has a story to tell, whether you work in a rural clinic or in an urban area, or regardless of your practice setting. You see firsthand, day to day, the impact and value that you bring to the healthcare system and the change that you make. And, kind of like the APTA's vision statement of transforming society, you each have a role in transforming society and see the value of what you bring to the table on that. And that's important for policymakers to hear because they're not going to hear it from anyone else. They're not going to hear it from other providers, and they need to hear it from us. And so everyone here has a role in advocating for our patients. And that's where membership matters, where APTA, being a member of APTA matters, being involved, being an advocate, and raising your voice and making some noise, as I always like to say. And so it's critical for you to be involved and to be an advocate for your patients. And we've seen the difference and that can make, that being a change maker, what that can do to the healthcare system, whether it's adding PTAs as authorized providers under Tricare. At the state level, we now have regulation of PTAs in every U.S. jurisdiction. I remember a couple years ago, back when I started at APTA, we had states that did not regulate PTAs, where they were unlicensed and unregulated. But again, it was because of the voices and work and advocacy of members of our PTAs who pushed at the state level to get those bills through, and at the federal level who pushed on all these critical Medicare payment policies and Tricare, that we're able to make that change. And again, to really show the value that physical therapy plays in the healthcare system and how physical therapy transforms lives. So, again, thank you for your advocacy. Thank you for being members, because it really matters. And we couldn't do what we do without you.
And Justin, that was very well said. I'll just add, there is a never-ending need on the part of APTA and our members to proactively advocate for the payment and policy changes that truly recognize the value of physical therapy. However, at the same time, we also have to continually advocate against policies that will harm the profession and the patients they treat. And so we need everyone to lend their voice to these efforts, both the proactive effort as well as advocating against any harmful policies that may be proposed by policymakers. And as Justin noted, your voice is really what counts and is really what can influence these decision makers in whether they change a policy or not. They want to know, does this policy impact you, the clinician, and the patients you treat? And it's your story that is influential. And so I just want to emphasize again, and I'm on Twitter if you want to follow me at Kara Gaynor, but in a lot of my tweets, I try to emphasize your voice matters and you have a lot of power with just your voice and you can do a lot with it. So I just wanted to end with that.
Great. Thank you both so much for being here. We would definitely like to invite you back for the future to maybe talk about more upcoming things and the looming payment differential, keep everybody updated and on the same page as what we can do to help fight that.
Well, thank you so much, and everyone stay safe.
Thank you so much.
All right. Thank you, everybody, for joining us tonight. And if you have any more questions that we didn't get answered tonight, you can email at advocacy@apta.org, and we can definitely get those questions answered for you. Thanks so much. And